All right. So, you have seizures.
Well, I guess.
Couple of basic facts that I want you to kind of understand. So, for starters, 1 out of 10 people in the United States is going to have a seizure at some point in their life. 1 out of 26 people in the United States is going to have more than one seizure. And when you have more than one seizure, we call that epilepsy.
So I have epilepsy.
Yes. Okay. Which, by the way, doesn't change anything about your life from a week ago or a month ago. You've had epilepsy all along. It's just that no one's ever known enough to tell you about it. Okay? Doesn't change anything about you. When a person has epilepsy, probably 2/3 of the time, we can get the seizures completely controlled with medicine. My area of specialty is actually that 1/3 of the time when we can't get the seizures controlled with medicine. That's what I really specialize in. Your situation so far is looking like it's actually pretty straightforward as far as the kind of stuff I have to deal with.
Okay.
When a person has seizures like this, more often than not, there's an area in the brain that's just developed in an abnormal way. Kind of like having a birthmark, except it's on your brain instead of your skin.
Sure.
And that sets up an abnormal electrical circuit, and that abnormal electrical circuit sometimes sets off a little spark of electricity, and every once in a while that spark will build up into a seizure. That seizure will be an abnormal surge of electricity that spreads across the brain surface, kind of like ripples in a pond when you throw a rock into it.
Yeah.
Right? So the bigger the spread, the bigger the seizure. So if you have just a little seizure, you might just feel a little panic, a little nervous, you might get a little confused, you might fumble with your clothes or chew on your, like you have something in your mouth when you don't. You might get confused to the point where you're not even aware of what's going on around you. And you might have a funny feeling in your stomach. As it gets bigger, you might have a little bit of twitching or shaking here or there. And as it gets to involve the whole brain, you can go into a full-blown convulsion, what we used to call a grand mal seizure.
Which I probably have been.
Yeah. So based on the way the seizures have been described to me by the other doctors and by your family, it sounds to me like the types of seizures that very often come out of the temporal lobes, one side or the other. Don't have enough information to be able to say which side.
Okay.
All right. So it really kind of is what it is, and you can, if we can get you on a medicine and get you to take it on a regular basis, I think that there's a decent chance that we'll have you completely seizure-free, no seizures, no side effects, normal life.
Sweet.
Okay, that's my goal for you.
Sweet.
I understand that the Depakote actually worked pretty well for you for a while there.
Did it?
When you were taking it regular. Okay? I got a buddy down in New Orleans, runs one of the epilepsy centers down there. You know what he says? He says the pills don't work if the people don't take them.
Very true.
My understanding also is that Dr. Mumford kind of got stuck with you in that part of the reason you stopped taking your Depakote or weren't taking it regularly was because of a cost concern in terms of the tribal insurance and what they would cover. And so he put you on phenobarb, which is a crummy old drug that's been around since 1912. It's a barbiturate, it's addicting, it makes you sleepy. And I'm not super excited about using that drug in pets, not much less in people. I can understand where he was coming from with it, but I think there's better options.
Yeah.
Because you had this bigger seizure that landed you in the hospital with a tube down your throat and everything, even though you were taking the phenobarbital, Dr. Irwin... Well, Dr. Irwin picked a different drug for you. She started you on a drug called Keppra.
Keppra, I've heard of that.
What I can tell you about Keppra is this. First of all, if I got seizures tomorrow, the first thing I'd try for myself is Keppra. Okay? It doesn't have much in the way of liver metabolism, and it doesn't have much in the way of binding to protein in the blood.
Okay.
It has no drug interactions.
Nice.
It has very few side effects. It's pretty well tolerated. You got to take it twice a day, but most people do real good with it. There's one major issue with Keppra. That major issue is that about 1 out of 10 people who goes on it will find that it makes them a little more grouchy or irritable. If they have a history of depression or anxiety, it can actually make those things worse. And you have that history, right? That's why Dr.
Yeah.
Mumford went to Depakote with you in the first place, because he was looking for a 2-for-1.
Yeah.
He wanted you to have something that worked as a mood stabilizer as well as a seizure drug.
Yeah, but I haven't been on anything for a long time that I'm aware of.
Now, you were taking the phenobarbital pretty regularly.
Was
Yeah. But again, that's going to work for the seizures. That's not going to do a whole lot for the
No.
other stuff.
And it obviously didn't work for the seizures, too. So.
Exactly. So, quite honestly, Heath, I would say that we've got a couple of choices here, okay? And my job, you got to understand, even though I'm getting to be and look a little older, I still think of myself as a newer generation of doctors. My job is to give you information and advice.
Alright.
I'm not going to follow you home and make sure you take my advice.
I am.
I would say that one option that's probably a pretty good one is to just stay on the Keppra and see how it goes. You're already on it. You seem to be tolerating it. It seems to be controlling your seizures, and it doesn't seem to be making you crazy.
Not yet.
So it would be real easy to let you go
You want the
on
seat?
Keppra and just see how it goes. And if you run into a problem, we'll deal with it.
Sounds good.
And in terms of getting the insurance to cover it, I'm really good at yelling at insurance companies.
Okay. Sounds good.
Because if they had allowed you to stay on the Depakote, if they'd paid for the Depakote, they wouldn't be paying for this hospitalization. And I guarantee you that the amount of money they're spending on you on this hospital stay is more than it would have cost to keep you on Depakote for the rest of your life. Okay?
Okay.
So, that's option number one. Just stay on the Keppra, see how it goes. We run into problems, we'll get you onto something else.
Okay.
Option number two is to say, look, there is some depression and anxiety here. The depression's pretty bad at times. Maybe it does make sense to be on a 2-for-1. Maybe we should go back to the Depakote, let the Keppra go.
It's all up to you guys.
I know, but you gotta weigh in on it a bit.
You don't have to make a decision now, just stuff to think about.
But I'll tell you actually what I would recommend. If you're kind of putting it back in ball in my court, here's what I would say. I'd stay on the Keppra for now. And the reason I say that is this. If we need to have you on a seizure drug that also works for depression,
Keppra would be it.
well, Keppra doesn't work for depression, but I can get you from Keppra back to Depakote, or from Keppra to something like Lamictal, which also works for depression. I can get you from Keppra to those other drugs pretty easy,
Okay.
because there's no drug interactions.
Okay.
If I put you back on the Depakote, and I've abandoned the Keppra because of the psychiatric stuff,
Right.
where do I go next if the Keppra doesn't pan out for you?
Right.
Getting from Depakote to other stuff is more difficult because Depakote has drug interactions, whereas Keppra does not. The other thing is Depakote requires blood work, which Keppra does not. And so while I recognize that there's a little bit of a risk here in terms of depression and anxiety with a staying on the Keppra, as long as you promise that you're not going to do anything crazy, you're not going to hurt yourself, you're not going to hurt anyone else, and your family's going to be watching you, and if you're turning into a total ass, they're going to call me and say, we can't live with him like this, then we'll get you into the office, we'll make a change.
Right.
Does that make sense?
Sounds good.
All right.
Can I get out of here yet?
As far as I'm concerned, yes. It kind of depends. I'm not the guy in charge of your hospitalization, but from my perspective, yeah, I'd be fine with you going home on the Kepler today.
Okay.
Here's a copy of. Here's my card.
Thank you.
So you can get in with me sometime in the next couple of months to see how things are going. Okay. It would probably be a good idea to get an EEG done at some point between now and then. I explained this to your family yesterday when you were kind of asleep, but I know you guys were kind of concerned and upset that the MRI and EEG didn't show anything when you met with Dr. Jernis. And I just want to set your mind at ease to say that, look, MRI can only see so much,
Right.
and sometimes the problem's too small for the MRI to see. If you do a better MRI, you get a better picture. You had your MRI done at Mercy Medical Center. Their magnet isn't very strong. Their image quality isn't as good as what you can get at a bigger imaging center.
Okay.
And so we're going to want to get a repeat MRI done on the outpatient side, probably at Intermountain Imaging, because they have the strongest magnet in town.
Okay.
Okay? They're more of a St. Al's than a St. Luke's, but I don't buy into the hospital politics. I go where the test is more likely to be good. The EEG is the other thing. It's a snapshot of how things go electrically in your brain for 30 minutes. We're looking for those little sparks. Remember I told you you have those sparks that sometimes can lead to a seizure?
Yeah.
The medicine doesn't make those sparks go away. That's why we're looking. That's why we're doing the EEG, even though you're on medicine. We're looking for those sparks. But if those sparks don't happen, that's useless information. It just means nothing happened, right? It's kind of like you take a look outside the window, it's all sunny.
Yeah.
Can you tell me whether or not it's going to snow tonight? No. You can't do that just by looking outside the window. Same thing with an EEG. Not seeing an abnormality doesn't mean you're not going to have a seizure. It doesn't mean you don't have epilepsy. It just means nothing happened during that test.
Right.
And so you need to repeat that EEG from time to time until you get the information you need.
Right.
Okay?
Can I get my clothes?
I'm not in charge of your clothes, but
Get ready to leave yet?
No, you got to take a nap and eat something.
To take a nap and eat something?
Yeah, they got to prepare the paperwork cupcake.
I'm ready to be going.
I know.
I'm home already.
all right. So from my standpoint, you're good to go. If they let you go, that's all good. Make an appointment to see me in a couple of months. If you call my office this week, I will make sure that they know about you, and they'll help you set up the MRI and the EEG before your visit with me.
Okay.
Fantastic. We're on top of it. Thank you.
All right.
Heath,
Nice to meet you again. I'm Rob Wexler.
Rob Wexler.
Yeah.
I think